So, hello, welcome back to the second presentation about implant treatment. Today we are going to talk about several concepts on osteointegration, mucointegration, and choosing the implant system. As you know, it is very important to understand all these concepts that basically have to do with the hard tissue and the soft tissue. And when we come to choose our implant system, it's also very important that with the amount of systems that are out there, a million, well, thousands of brands, thousands of connections, well, different types of implants, it is very important that you understand, that you try, and then afterwards you choose the implant system that you like. So I do not know if you have questions from the previous lecture. If you do, again, you can always send me an email. You can also contact me on the social media, so please feel free. I'll be more than glad to help you in every question that you might have. Good. Without further notice, we will continue. So the agenda for today is a little bit of understanding the history and the concept of osteointegration, how it came into this concept of osteointegration. Also important to understand the soft tissues around the implant rehabilitation, the mucointegration. We're going to talk a little bit about implants, different type of implants that we can have, and especially about the external and internal connection. What are the differences and how can we benefit the most from each one of them? So it is very important to understand that losing teeth has always been a problem. Has always been something that it's not from the modern days that we try to replace the teeth that are missing, but it's something that we see along the time that was already a concern. We can see, for example, in the year 2500 before Christ, the Egyptians, they all already were the gold ligatures in wire, where they use the tooth that the people have lost in order to place them back and to restore the use, the lack of the teeth. Also, in the ancient times, many times the teeth that were missing were many times replaced by animal bones, also, like we can see from the Etruscans, also by shells like the Mayans did. So it is understandable that this is a problem that always has been a concern in terms of trying to deliver some fixed teeth again. So what does the evolution tells us, and what has been the solutions along the times? Well, along the times, many different types of implants have been weared. Not anymore is used, of course, the shells or the other type of bones, other type of animal bones. But we have, in the last century, some types of different implants, like the transosseous implant that was used in the mandible. We have intraosseous implants, which are implants that stay inside the bone. We have superosseous implants, that are implants that will embrace the bone. And we have then the endosseous implants, that are implants that then are going to be directly connected in the bone. So you can see here a picture from the transosseous implants, which was basically a type of plate that was put underneath the mandible. From that, there would be some screws that would cross actually the mandible, and then would have this type of locators to which then the prosthesis could be done. Of course, you can see this was a solution. It's very invasive in terms of how to do it in terms of surgery. but it was one of the first fixed solutions when you were a dentalist. Intraosseous implants are implants that were also very common in in the last century. We had the most common was this type of plates that were then also used for partial cases, but also for indentals. Here you can see in conjunction a ramus frame and another blade in the front, and from that we would have then a prosthesis that would be cemented or removable one to that kind of pins that we had this ramus frame and blade coming out from. This was a case where unfortunately we had it was not functioning. We had to take it out, and we did an all-on-4 standard approach in this case. Another type of intraosseous implants are these in needle shape, as you can see. Also possible, this type of implants, where then you had crowns that were cemented to these type of implants. So you can see over the years we had different types of solutions. Many solutions used in conjunction in order to basically help our patient to achieve a better stability of their chewing, their function, their capability, and also the aesthetics. Superosseous implants are implants that would embrace basically the bone. By this time the surgeries were complex because you had to open everything. You do an impression then to the bone of the patient intrasurgically, then you would have these superosseous wires being done during the surgery, and it was a very time-consuming surgery, it was done under general anesthesia usually, and it was very costing for the patient, and basically they were wearing over this then also removable dentures. So this was a case that we had to take everything out and do fixed bridge. Nowadays, superosseous implants have also evolved. They have indications in some cases. This was a case where actually a normal implant treatment failed, and that I sent to two colleagues of mine, Jose and Miguel, Jose and Luis Mesquita. So, and they actually did the surgery, allowing the patients to have fixed teeth. So the superosseous implants have still nowadays an indication where we have very atrophic mandibles or maxillas, and where the endosseous implants are not a solution, or where the risks are higher in terms of mandible breaking the mandible, or when it's very atrophic cases. So this is still a solution nowadays. But of course, the most common implants are the endosseous implants. So we know that the endosseous implants are the most common nowadays, because these implants are the one that have the most successful rates in terms of tooth replacement. Now, how does this work? How do these endosseous implants work? Well, basically, it's very important to understand the history. You know here Professor Brainmark. Professor Brainmark, he was an orthopedist, and he was doing his research in checking exactly how the microcirculation in rabbits was done. So what happened was that when he placed a titanium screw in the rabbits to check exactly how the microcirculation around it was being done, afterwards he wanted to take, after some months, he wanted to take the screw out, And what he realized was that this titanium was completely integrated inside the bone. So it was very, very hard to remove the titanium screw from the bone. So what he actually defined was the concept of osteointegration, and this concept is a concept where he defines it to be direct functional contact between the living bone and the surface of a dental implant. So actually, from his research, he started to realize how beneficial it could be to put that in other fields, meaning in the dental field. And so he started to work, although he was an orthopedist, he started to work also as a dental surgeon. And in 1965, the first patient, a taxi driver who had cleft palate, was the first patient treated with dental implants. And actually, this patient died in 2006, so 40 years later, still with the implants in his mouth. So he, Professor Brainmark, saw that this was really a major breakthrough in terms of dental rehabilitation and in terms of oral health conditions for patients, especially patients that were mutilated or patients that had no teeth at all. So he saw here a big breakthrough in order to be able to help these patients' life. So he continued his research. He continued to publish his research on fixed teeth over implants. So he was very into the edentulous patients, as I said. So in 1983, he published this publication in which he basically used 4 to 6 implants for a total rehabilitation and connected them with a fixed bar. So they had 12 years of follow-up in this particular case that we can see here, and you can see how the implants are in terms of the bone, how they continue to be integrated in the bone, and how they support such a big bridge. And we are talking here about small implants. So the work that Brainmark did in terms of the osteointegration, meaning the concept of osteointegration, and seeing the potential of these titanium implants to be able to help patients, especially dentalist patients, to have better condition, was a really breakthrough. So, and from that on, it was just a matter of time for it to become one of the most popular and successful treatment in oral and dental health. So, of course, with this major breakthrough, one of the biggest sentence that Brainmark has always said is that this statement is so important. No one should die with their teeth sitting in a glass of water. And basically, this is what we are continuing here, this education and the ability to provide us, our patients, with fixed teeth. So when we think about the implantology and providing our patients with dental implants, the biggest goals in implantology are to have osteointegration, to have then these implants that integrate into the bone, but we want to have static restoration, and we want to have soft tissue stability for a long time. So this is very important, and for that there are some rules, some parameters that we have to take into consideration. So when we think about these endosseous implants, there are several implants in the market, more and more to come. And we know that today more than 1,300 types of oral implants, varying in form, material, dimension, interface geometry, surface properties, they are commercially available. So there is not one better than the others, so to say. You have to find yourself the perfect one for you to use. And when you start to use it, the best is that you find one solution, one implant system, and that you try to use it for the majority of your cases, because with this your learning curve will always improve. And this is what we want, is for our learning curve to improve and to know exactly what to expect from the bone and from implant that we are using. So when we come to the implants, we have the implants having its macro design, micro design, and its type of surfaces. When we talk about the macro design of the implants, we have implants that are parallel walls, like this one, like the Noble Speedy, but has a tapered apex. We have conical ones, like the Active. We have flat. We have implants with hollow. We have also perforated and no perforated implants. We have threaded and no threaded implants. So it's important to understand that just for the macro design, just for the form of our implants, we have many different types of implants. Now, depending on what you want to do, you will decide for one or another. So, for example, when I look at the concept of osteointegration and the concept of achieving a high primary stability, I prefer to go for an implant with parallel walls, but the apex at least has to be tapered in order to allow me to do an under preparation, to allow me to place the implant and the implant to push the bone and enhancing its primary stability. We'll talk about this also in the next session, where we are going to talk about some tricks how to improve and to get a good primary stability from our implants. So thinking about having smooth surfaces or surfaces that are threaded, of course, threaded implants lead you to a superior stability. Basically, it will let you achieve a higher primary stability at the moment of placement. It will have also superior adhesion to the surface, and you'll have a higher bone implant contact. Okay, bone implant contact is very, very important for the osseointegration, but especially also for the maintenance long term. So you want to achieve this higher percentage. And of course, when it comes to strength distribution, you will have a superior strength distribution of it. So threaded parallel wall implants is actually what we usually aim from. When we talk about the width and lengths of the implant, so we can have different widths, different lengths. Each brand will vary a little bit from case to case. We have, I like to use Noble Biocare components, but of course you can choose another brand. Each brand usually has a narrow platform one. In Noble Biocare it varies from 3.3 millimeters till 375. We have the regular platform that usually goes for 4.3, and the wide platform more than 5 millimeters. So here, for example, these are all the lengths that we have from this type of implant, which is the Noble Speedy implant. So we have a narrow platform, regular platform, and wide platform from 7 millimeters length, okay, till 18 millimeters length. And then we have also the regular platform for longer implants, 20, 22, and 25, and also for zygoma implants. So it is important that you know the portfolio that you have from the implant that you are using, because sometimes you have very short bone where you can adapt short implants. Sometimes you have very straight crests that you can adapt the narrow implant, and sometimes you have very soft bone but a lot of bone that sometimes you will need very long implants to achieve good primary stability. So it is important that the implant that you choose to have has a big variability of implant length and implant diameters, okay, so that you can adapt to all the cases that you have. So I use the Noble Speedy with the external connection, or I use the parallel CC for the internal connection. In terms of the implant bodies, they are basically the same, parallel walls with a tapered apex, and then what the difference is basically the connection. In terms of the surfaces of the implants, we have different types of surface. We have addition surfaces, we have subtraction surfaces. Addition is when you add something to the surface of the titanium. Subtraction is when you make a treatment to the surface where you take something out, like for example the anodization, or bioactive surfaces where you then also put something that is bioactive in the surface of your implant. So for example, when we go for the addition surface where you have titanium TPS, the titanium plasma surface, for example, it leads to a rough surface. It results from the treatment of a machine implant with a titanium plasma jet at high temperature and velocity. It leads to a 40 to 50 micrometers of thickness and 7 of roughness. And it will lead to 80% of increased area. When we go to the subtraction of using the thionite implants, it was then introduced in 2001. It's an anodic oxidation process where basically we have electrolytes that will lead to this oxidation, anodization of the surface. It will increase towards the apical of the oxide layer, 10 microns, and the roughness will be on the coronal part less and on apical part more. It's an isotropic surface, and 37% of increasing of the area. So also what we know is that, as you can see here, these are the difference between the most coronal part and the most apical part of this subtraction process. Also other evolutions in here, talking about the thionite surface. Nowadays we have a new surface which is a Thi-Ultra surface, which is also a process of different anodization through the implant, through all the implant length. As you can see, there will be a gradual change in the topography from the apical part, aiming for a better osteointegration, coming more to the coronal part, where basically you can see this nanostructure oxide layer that now in that part is non-porous, in order to prevent any type of accumulation of the bacterium plaque, and in order to prevent more bone loss once you have the remodelation of the bone crest. You also have the subtraction from the SLA that was introduced in 1997. Basically what happens is that you have a jet with coarse grained particles of aluminum oxide or titanium oxide under a controlled pressure. And then you have the wall etching at different temperature and period of time. It will lead to a 33% of increased area and superior alkaline phosphatase action. Then from this area you can also have another addition of the surface, where this area is then the SLA active, for example, of the Straumann implant, is then impregnated in isotonic NaCl solution. So As you can see, there are very different types of surfaces and treatments of the surfaces. What we see is that we see a big change in terms of implant success and survival rates compared to the surface that we have in the beginning that were all machine surface. So coming to the type of surfaces that polished or rough, what happens is that we can measure this roughness, the topography in units. Being the roughness, we can measure in SA, average high deviation, which means peaks and valleys average in 3D perspective, as you can see, and also SDR, which is the developed surface area, represents gain in the surface that we have. So we have very smooth surfaces when the value is less than 0.5 microns. Usually polished abutment surface is considered to be like that. Minimal rough surface between 0.5 and 1, that were the machined implants. And we have the moderate rough surface between 1 and 2, which is the most commonly used types. And we have the rough surface like in the plasma sprayed surfaces. So you can see here the differences between them and how they actually will increase then the area, the surface area. So in terms of conclusions, the surface topography on a micrometer level influence the bone integration. Moderately rough and rough surfaces will provide enhanced bone integration compared with smooth and minimal rough surfaces. The highest level of bone to implant contact, that's what I was saying, was associated with moderately rough surface. So moderately rough surfaces is basically what we aim from. No one of the implant systems was found to be superior in marginal bone preservation, and there is no evidence that the modified surfaces are then superior to modified implant surfaces in the marginal bone preservation. So again, like I was saying, we have to find a type of implant that works, of course, that has research behind it, but there is nowadays what is very important is that you find one implant system that you can use to to all your cases. Here, for example, I like to use one implant system, like I said already, no way care, the parallel walls, so being it the speedy, being it parallel CC, and then two different types of connection. The internal connection, like I have here for the parallel CC, the prosthetic connection that I have here for the external connection that I have here for the Nobel Speedy. So when it comes to external internal connection, the connection is fundamental to understand the stability of the junction, the strength of the junction, and the locational and rotational stability. So, because we want to understand and to have a good prosthetic stability. So the original connection is the external connection that was original for the brain mark protocol. It was used mainly for the total and dentalists with fixed prostheses and had an external hexagon of 0.7 millimeters high, which was anti-rotational. The advantage is an implant that we have a long-term follow-up data that we can use for frequent utilization, and it has multiple clinical applications from partial to total cases. Now, what happened and what was one of the biggest disadvantages of the external connection was that more commonly we saw screw loosening. There would be a mechanical failure of the anti-rotational hexagon on the 0.7 millimeters of the hexagon, which the resistance was between 60 and 80 Newton centimeter. So then sometimes also in terms of the prosthetic rehabilitation, it was difficult many times to have a good connection of the abutment because the hexagon was very short, so it would not lead precise to where you want. Sometimes you could have then this micro gap between the abutment and the head of the implant. So the development of these, in order to try to diminish the unscrewing of the screw, basically it started to the development was to limit the fit but small fulcrum, to have a higher hexagon diameter and high, which means instead of 0.7 to have the 1.2 millimeter. Also the screw modification with a bigger specific torque application and the more precise adaptation of the abutments to the head of the implant. So nowadays I like to use very much the selection of the external connection for multiple reconstructions, for partial and total edentulous cases, because in terms of flexibility of the prosthesis, they give me more prosthetic options for the angled abutments and implants. And they are then very easy to connect, but they will allow me then more possibilities of my insertion axis in order to place my prosthesis. And this is because I am using angulated also tilting of my implants. So the compensation of using angulated abutments is important, that I have, especially in very extreme cases, that I have more possibilities in terms of the rehabilitation. Nevertheless, what happened was that it was basically considered a problem and still not a problem, but a big challenge in implant dentistry, this unscrewing of the external connection of the external connection implants. So in 1986, Gerald Nixon, an inventor, he came up with the internal hexagon, with the internal connection implant. So they were 1.5 millimeter depth. We had two types, one of the friction fit and one of the passive fit. So basically this internal connection will improve the connection stability in function and at implant placement. It will simplify the instruments that are then required to carry out the rehabilitation. It's more easy because it's inside, it's more easy to connect. So you feel well the fitting of the abutment in your implant. Of course, the advantage here of the internal connection are diminishing the screw loosening, easier abutment fit. It will reduce the height of the platform you need, which will then lead you to a better superior occlusal space that you have in terms of advantage to put your crown. Also, the distribution of lateral loading inside of the implant, that's what we see, and will lead to less eventual marginal leakage. So the disadvantage for this is that you have less prosthetic positions for the angled abutments. In the tripod connection, you then have only 3 positions possible. For the conical connection with 6 positions, then you only have the 6 instead of the 12 of the external connection. And when you have very, very high torques, it can be less resistance when you are placing the implant and doing too much force on the implant head. So in terms of unitary rehabilitation, I would advise to go for an internal connection. When we think about, okay, for unitary connection, for unitary rehabilitation, yes, go for internal connection, using internal connection, because it will diminish the possibility of screw loosening. It will have an easier abutment fit. It will allow you to have higher aesthetics, less eventual marginal leakage, and better distribution of lateral load. So you can see here, this is one of the cases. This case, as you can see, has a need for an implant in the first quadrant, in the area of tooth number 16. We do the CT scan, we measure the CT scan. As you can see, we have 9.6 millimeters of bone height with 10.6 millimeters of bone width. So we do the OPG, the CT scan, and then we have our patient smiling. And then what we do is, here you can see my implant, a 4.3 times 10 millimeter parallel CC. The type of bone was medium, so I drilled full length with the 2 millimeter, the 2.4 to 8 millimeter, and I drilled just on the cortical of the crest with the other two drills in order to achieve a high primary stability. In this case, I achieved a stability between 35 and 50 Newton. Okay? So this was an implant I could actually go for immediate prosthetic rehabilitation, but it is in the area of the first molar, so you don't really have this need. Here you can see the patient with the implant and healing abutment. You see the periapical x-ray, where you can see actually having a bicortical anchorage on the tip of the sinus. Okay, and here you can see also the relationship between the neighboring teeth. Perfect. Here you can see the patient already with the final rehabilitation with a Procera crown in place and in occlusion, all well. Okay, so it's always very important to make sure that when in these rehabilitations that you have good fitting, precise fitting between the abutment of the crown and the implant head. Also that the crown, when you has a very nice relationship with the soft tissues, as you can see here, and also when you pass the floss between the teeth, that it goes well down and up without, so that you have also a nice contact point between the adjacent teeth. So continuing, knowing that one of the biggest challenge that we have in terms of the goals in implantology are that also we want to maintain very nice soft tissue stabilities. Now, when we talk about the implants, we know that the implants are different in terms of biological stabilities than compared with the periodontal anatomy that we have around teeth. So it is very crucial that you know exactly the peri-implant anatomy that you have on the implants, because this will actually change the way you address, the way you do surgery, the way you do prosthodontics, and the way you do the maintenance long term. So we have a hard tissue compartment that on the bone, between the bone and the teeth, when we have teeth of the patient, we have between our bone and the teeth, we have the periodontal ligament. Okay, so the tooth is not completely connected directly to the bone, so we have the ligament. Okay, and we have vascularization. On the other part, on the implants, we have the osteointegration, which is a direct contact between the bone and the implant surfaces. Above this, above the bone, what do we have? We have the soft tissue compartment. In the teeth, we have the connective tissue and we have the epithelial attachment. We also have this in the implant, but the lengths that we have are different, and the connection from them is also different, okay? So as you can see here in our implant, in our teeth, we have the dental-gingival complex, which is around 2.7 millimeters. Of course, it differs from several teeth from the front to the back. This is an average, okay? So we have a sulcus, usually of 0.69 millimeters. We have the epithelial attachment of 0.97, 1 millimeter, and 1 millimeter also of the connective tissue attachment, which will lead to a biological width of 2.04 millimeters. Now, when we look at the implant, this is different because we have a bigger epithelial attachment of 2 millimeters and a bigger connective tissue attachment of 1.5 millimeters, leading to a biological space of 3.5 millimeters. We can see exactly how the teeth, the connection between the soft tissues, the epithelial connection, is compared to the connection that we have between the teeth and the soft tissues, or the implants and the soft tissue. So it's a much more fragile connection between our abutments, or between our tissues. But as you can see, the hemidesmosomes go parallel to that to the surface of the implant, while in the teeth you have a big linkage between the tooth, okay, and the periodontal, the periodontal being the epithelial, the junctional epithelium. So this is with the connective tissue. So this is very, very important, because we know that when, for example, we probe our implant, around our implant, the linkage that we have, it's much weaker. Now, we also know that the implant stability and function depends on this barrier that we have, transmucosal functional barrier. So it is very, very important that we have this connection the more stable as ever. So what happens after placing an implant? What happens in the healing? Well, we have the day 0, where we start to have coagulum formation. Then we have from day 0 till day 7 the substitution of coagulum to granulation tissue. After this, we will have this substitution of the granulation tissue to connective tissue. In week 1, week 2, we start to have the proliferation of the epithelium. And then week 4 to week 6, the collagen fibers organization. Why is it so important? Because during the time that we are basically building this organization and this functional barrier, we do not want to touch anything. Actually, we would love to place the abutment in the day of the surgery and not touch it anymore. So we have between 6 and 8 weeks, we have the epithelial barrier that is formed. So this transmucosal functional barrier, it's very, very important. And how can we improve its maintenance, and what can we use in order to try to maintain it as maximum as possible? We can see that over the years there were different types of implants. We have bone level implants and we have tissue level implants. Now, one of the advantage of the tissue level implants is that actually they are bringing the micro gap higher, not at bone level. So this micro gap between the rehabilitation and the implant itself is higher it's on the level of the soft tissues, allowing the soft tissues to heal well around this neck of the implant without disturbance. Now, the thing is that with the bone level implants, you have the implants on the level of the bone. So you have this micro gap on the allowing for more sensibility to changes on the bone when it's healing. Now, what would you like to have? I would love to have an implant at the bone level, but with a platform that I would put in the same day, and that would have flexibility in terms of height, so that I can choose exactly what this abutment is in order to connect then my prosthesis. That would be the best from the two worlds, having the micro gap upper but still allowing for different type of rehabilitation. So in this thesis from Katarina Gottberg, we can see actually the implant level, when we have, for example, the use of abutments in between, then going into the head of the implant, that we have less bone resorption. Well, so this is basically what we would like to have. So we would like to have this bone level implant, but with one type of abutment that would give me flexibilities in order, depending on the type of soft tissue height that I have, in order to connect it, transform it into a tissue level implant. Okay, and from that on I would do the crown over it. So as you can see here, in this case, this is a case where I had to do an extraction of the second premolar because of fracture. So I did the extraction, and in the same day I placed an implant. So I placed a parallel CC implant, as you can see here, and also placed this abutment, which is the on-one abutment. So basically this abutment transformed a bone level implant into a tissue level implant. So I screwed the on-one abutment with 35 Newton, and then the provisional crown was done to the on-one abutment. Screwed it with 50 Newton. You can see here the provisional crown. So after 4 months, we do an impression on the on-one abutment, as you can see here, and we connected here a crown, single crown, to this on-one abutment, as you can see. So basically what we did in this case is that we transform a bone level implant into a tissue level one, trying to put the micro gap more to the up, trying to benefit from the both of the worlds. So this concept goes to the same of one abutment one time. Why? Because we know that when we start managing a lot the soft tissue, sometimes this managing of the soft tissue can actually lead to this apicalization of the soft tissue. Why? Because if we several times do abutment disconnection and reconnection, it can lead to the breaking of this functional barrier of the soft tissue, and we'll have this soft tissue apicalization with then bone resorption. This is stated, for example, in this study from Abergson and Berglund and Linda. Of course, this was an experimental study in dogs, but this is something that we also see in other clinical studies. For example, if we see this abutment changing and the stability of the soft tissue, when we go for these clinical studies of Molina and Sanchez from Juan Blanco, you can see that basically in the cases that we had one abutment one time, we had less bone loss than the one that we had to change the abutment. So 1.24 millimeters versus 0.61 millimeters. Also, Exposito stated that we have more bone loss in when of plus 0.16 millimeters when we have repeated changings of the abutments. So this might influence actually the bone around our implants. So this is very important to try to understand that we have to try to make this intact, this barrier. And in my opinion, I think this is one of the biggest secrets of the All-on-4 is that we try to place the abutments inside the implants, try to connect in the day of the surgery, and in that day we try to maintain, if possible, that abutments forever. Everything we do is at the abutment level, so we try to maintain intact that barrier. So you can see that, for example, from the two publications that we have in 2019, being it for the mandible or for the maxilla, you can see that we have 95.9% of success rates at 10 years of our implants with 1.72 millimeter of bone loss. In the maxilla, we have 95.6%, also 10 years, with 1.67 millimeters of bone loss. So again, I think that placement of the abutments is crucial. When I see, for example, when I show you this case, this was a case that came to us in 2008. The patient had already that rehabilitation in the lower jaw. We did the All-on-4 on the upper jaw in 2009. You can see in 2010 the final rehabilitation. You can see here the periapical x-rays, and in the upper jaw we see that we are going to abutment level. In the lower jaw we are going to the head of the implant. So you can see here the differences, but more evident is actually that we have these big differences between the upper soft tissue and the lower soft tissue. So you can see here, when we go to check our mucosa, when we do our maintenance controls, because we do our maintenance controls, we will talk about that in one of the sessions. But it's important that you take the prosthesis out, that you check exactly if the abutments are okay, are not loose, that you probe, that you see if you have separation, you look at how the soft tissues are, and here you can see that you have a little bit of inflammation in the lower jaw where we go to the head of the implant. So we clean everything, and of course it's also stable, but we can see that when going to the head of the implant, we see more inflammation of the soft tissue, and also we see more bone loss around our implants. So very important to try to maintain this soft tissue barrier as much as possible. When it comes to the abutment surfaces, also we had, as you can see here, we see that this is a trend for the future. Not only the surfaces of the implants will continue to have more evolution, especially in the different sizes, in the different parts, in the different lengths of the implant itself. As you can see, like I stated, the new Ultra surface of Nobel by Care has different treatments in the the several length of the implant itself, aiming in the apex for a more osseointegration, and in the corneal part of the implant less roughness and a better way of having a better mucointegration. So the abutments themselves, we have, this seal surface, for example. Maybe other brands also have other treatments for the abutments, but this surface, basically is an anodization of the surface that will lead to different needs. The implant collar and the abutment surface must satisfy different needs, because what are the needs that we want? We want the tissue to integrate the abutment, but we also need something that if suddenly we have adhesion of the bacterial plaque, it is easy to clean. So cleanability and tissue integration must be put on the balance, and understand how to improve it. So this seal surface is a surface that is a smooth anodized surface, smooth anodized abutment, as you can see here. And this golden color is a nanostructure oxide layer, non-porous, but it will enhance the surface chemistry. So basically, it will enhance the adhesion that you have with the soft tissue. So it was actually studied already in terms of the human gingival epithelial cells, showed actually a significant faster growth on the seal surface compared to the machined surface, as you can see here. 1 day more or less the same. At 3 days we already see the difference, and on day 6 also a bigger difference, as you can see here. In this randomized controlled prospective clinical trial between seal surface and machine abutments, we can see it was a comparative split mouth design, the seal versus the machine abutments, and follow-up time was 2 years. And what we see is that basically the ones with the seal surface showed a higher keratinized mucosa of 2.37 millimeters compared to the machine ones of 1.79 millimeters. Also 4 times less bacteria on test abutments, and also lower soft tissue bleeding upon abutment removal. So it showed stable bone levels. Actually, we are also conducting a study on the Olin 4 with the TI Ultra and the seal surface. And actually, in terms of biological complications, we are having very, very good results. We haven't yet had biological complication, although it's a very shortened study yet, only with 42 patients, but only one year of follow-up. But I really think that the surfaces of the implant of the abutment will also play a bigger role in the future. So now I want to finish just one case, one surgery. This is a case where I went for an implant in the area of the 36. So I open a flap between here I wanted also to do a crown lengthening in the area of the 35. So I use here an implant of internal connection. I start with the start drill. Now I go with the precision drill. This is a drill of 2 millimeters, and this is a special drill with roll low rotational without any saline, any irrigation. So this is a new implant, which is called the N1 implant, which we will talk later about this, because I think it's a very interesting way of preparing, and I think it is also a breakthrough in implantology. And here we are placing our implant. Is an internal connection implant with of 3.5 millimeters in terms of diameter, the narrow platform, here of 4 millimeters, the regular platform, and then you also have wider platforms. This is a 4 millimeter implant in terms of diameters, and 10 millimeters of length. So here we connect our abutment. It is a healing abutment. I like to leave it to heal. I suture everything, and then after more or less 4 months we go directly for the final rehabilitation. So here on this case also, it was a patient that had in which we had an implant with internal connection, unitary implant. It was a very, very interesting way of drilling. So it's a drilling trying to maintain as much as possible the viable cells. And also it's a rehabilitation that will lead to a very good stability in the future, because what happens is that this internal stability is also, this internal connection is a very strong connection. So I hope you enjoyed this session. I'm looking forward for the next one. Meanwhile, again, here you have my social media contacts. If you need anything, you just write me. Thank you for everything.